Yeah, thank you everybody for attending. I'll just bring up my slides now. And for the slideshow,
yeah, we can see those.
You can see that, okay? Yeah, perfect. So my name is Dr. Balraj. I'm a GP, like I said, with special interest in urology and diabetes, cardiovascular. Spent about almost a year at City Hospital doing urology over a few jobs, and I had a great time at that point and developed a great interest into urology and different sort of conditions. A lot of it, which we see in primary care, which we don't necessarily think too much about, and a lot of things that like Jazz says, patients come in about another problem and say, "Oh, by the way, I've got this problem," or "By the way, this is happening," or they're asking for pads, and there's an underlying issue behind it, or people are embarrassed to talk about these conditions because it can affect you at younger or mid or late ages. So what I'm going to do is talk about briefly the background behind incontinence, the assessment, lifestyle, treatment, when to refer, red flags, and other sort of like consideration points. I've got a few case studies as well. I've tried to be as thorough but not too thorough as possible, so to go over the main sort of key points and like practical points for anyone in primary care. And also say thank you to Mr. Alan Sakrin, he's a urology consultant who helped me to check over the slides and make sure that the content's okay. So the background really is that there's three main types of incontinence that we see in primary care or in general, really. You have stress incontinence, which is essentially, simply put, involuntary leakage. So where people are passing urine against their, unwantedly passing urine, generally triggered by increases in intra-abdominal pressure. We'll talk about that exactly, but that's what stress incontinence infers. There's urge incontinence, which is where people have a sensation of involuntary, that they have to do a wee, they have to pass urine, and involuntarily, sometimes urine can be passed in small or large volumes. Okay, so that's urge incontinence. So we'll talk about that as well. And then there's overflow incontinence, which is largely down to a bladder outlet obstruction, a stenosis, stricture, prostate, etc., or detrusor underactivity, which has neurological reasons, drug reasons, etc. So we're going to talk about these conditions. I'm mainly going to focus a lot on stress and urge because that's a big part of what we're going to see in primary care. Overflow's got a big part for male. That could be a separate talk itself, but this is the big part of what we see and what we do. So when we do a history taking, there are quite a few questionnaires, like the IPS questionnaire for International Prostate Scale. There's quite a few different questionnaires on incontinence and how it's affecting people. What I find is that these questionnaires are generally more helpful for patients, well, for clinicians in secondary care settings when they're auditing the benefit of before and after. So like a pelvic floor physio, those sort of people, it's more important for them to have those scoring done so they can show before and after. But for us, it's really the main thing that's important is how is it affecting our patient, and then to determine what kind of incontinence it is and how best to manage it. I think there's a bit of feedback coming out, Jazz. Someone might have their speaker on.
Yep, I'll try and.
I might have to mute all then.
Yeah, it should all be mute now.
Yeah. Okay. Thanks, Jazz. So like I say, in primary care, you can do score scales and it can be really helpful for before and after. But the most important thing in primary care is how is it affecting our patient? How so what's happening? When is it happening? Why is it happening? And how is it happening? So So are they leaking without knowing they're leaking? Are they finding that they're wet? When does it happen? Does it happen when they're coughing? Does it happen when they're sneezing? Happen when they're giggling? Does it happen when they're jumping with the child on a trampoline? When is it happening? Why does it happen? Is it fluid related? Are they having any medication? These sort of things. And how does it happen? So what exactly is happening at the time? Probe the patient about urgency symptoms. Urgency symptoms are so difficult sometimes to gauge. You say to a patient, do you have to run to the toilet? Sometimes I do, sometimes I don't. How quickly do you have to go to the toilet? Do you feel like you can overcome that urgency? You can control it? Do you feel like you can't control it? Do you feel like you leak on the way there? So that's really, really, really important. And with urgency and frequency, if you ever ask a patient how often do you go to do a wee in the day, the answers are often incredibly vague. And that's because if I asked you now as well, how often have you done a wee, yesterday, I think a lot of people say, I'm not really too sure, maybe a few times in the day, but it can't give you a clear answer. That's because we're not necessarily thinking about it as part of a normal daily routine. But one thing that we do think about is how often do you wake up at night time to do a wee? So if you wake up 5 times at night to pass urine, then you will most definitely know that because it's going to affect your quality of life, affect your sleep, be annoying, these sort of things. Compared to in the day when you're already awake and about and you'll be drinking water, easy access to the toilet, it may be less burdensome, and you may not sort of have it at top of your priorities. Asking a patient have they bought pads is really, really key. Have they bought pads, and for how long have they bought pads for? Where are they getting them from? A lot of time patients will ask you, can you prescribe pads? Obviously we don't prescribe pads, but incontinence team can provide, or district nurses can potentially provide, depending on area to area. But then if they're asking for pads, there's obviously an issue behind it, and that's what we need to address. Like I say, when does leakage happen? What are they drinking? Is there caffeine? Is there high levels of fluid? Is there pop? So Coke, lemonade, these sort of things. They all play a big role. The other thing is, I suppose, with red flags. So do they meet two criteria? Do they have recurrent UTIs? Does that need investigation? Do they have hematuria? Do they have non-visible hematuria that's persistent? Do they get any sort of strange abdominal pain? Are there any masses they can feel? Are there any red flags? Scoring system, like I said, they can be helpful, but it won't necessarily change the outcome of your consultation. So it's not a necessity for you to do that, but it can be helpful, like I say, especially for people that are learning. Past medical history, so have they had abdominal surgery? Have they had radiotherapy? We'll talk about why that's important soon. Obstetrics, how many children have they had? How many pregnancies have they had? How did they deliver? Was it with forceps? Did they have an section? What happened during pregnancy? That's really important because was the child did they have gestational diabetes and the child was a large child and they had tears? That plays a massive role for the child, for the mom. Any other surgery, especially pelvic surgery, and drug history. Obviously, drugs play a key role into incontinence, depending on what they're taking. Anticholinergic burdens, one thing that we talk about. When it comes to LUTs, lower urinary tract symptoms, this is mainly for men that we talk about LUTs, but obviously for women it applies as well. And there's two types of LUTs. One is to do with storage, which is to do with the urgency, the irritation of the bladder itself. So how often do you do a wee? How much do you have to run to the toilet? Do you have to wake up at night time to storage the bladder? And do you get incontinence related to urge? That's really key, especially for men, but especially for women as well. And is avoiding LUTs. Avoiding LUTs really applies to men because they've got a long urethra compared to females, but still is important for both people. Do you have hesitancy? Do you have to get to the toilet? You can't, you've got to strain a little bit. Does the urine come out and stop start? Is the stream okay? How is the flow? Do you feel like you're emptying your bladder? That's one of the most important questions you can ask anyone. Do you feel like you're emptying your bladder, or do you feel like you go to the toilet, you pass urine, short splash, and then you need to go to the toilet again in about 10 minutes because you've not emptied it and you still feel like there's something left behind? That's a really key part of the history. Spraying of urine, so the urine sprays when it comes out. Does that mean that there's obviously a stricture at the urethral meatus? Is there dribbling after? That can suggest incompetence with the sphincters. So it's all key sort of questions for both men and women. Incontinence affects a large portion of women. 40% is the figure that I got. More women than men, more Caucasian women than Afro-Caribbean or Asian women. And that can definitely down to pelvic floor strength. But it generally affects women more because of their pelvic floor anatomy compared to men. And men often have obviously have a long urethra, which is protective against incontinence because of the way the pelvic floor works. Medication. Okay, this is a really busy slide. Just got to glance over the most important things. This was anticholinergic burden. So antipsychotics have anticholinergic burden, especially second generation. Antidepressants, some antidepressants, amitriptyline, TCAs, these sort of drugs, they can all cause urine retention, overflow. They can affect the ability for your bladder to empty. We give tamsulosin for prostate to allow relaxation of the prostatic muscle and the external sphincter. So if you have an alpha adrenergic agonist, so the opposite, that can cause retention, simply enough. Diuretics, is someone on furosemide, on spironolactone, what effect is that having on the bladder? Some people after starting SGLT2s can get overactive bladder symptoms. In the trials, it wasn't a major reported adverse event, but people do report it. So does it mean that you stop the medication because they're having that? Not necessarily. It can be risk benefit. Obviously, the SGLT2s having some benefit for that patient as well. Work out whether it's worth it or not. That's a discussion you have with the patient. And you can read the below, but I think the most important thing is anti-Parkinson's medication, anticholinergic medication, and diuretics are the most important medications that can sort of cause sort of problems in this area. So, so what causes stress incontinence? Stress incontinence being, one of the most important incontinences because majority of the way it's dealt with is either pelvic floor exercises or with surgery. The biggest way that this occurs is something called urethral hypermobility. I'm going to explain to you what that means, okay? Because urethral hypermobility makes you think, so water pipe being extra mobile, what does that mean? So your urethra passes out, and underneath the urethra is a pelvic floor muscles which bind around your water pipe, okay? And if you have weakness in the pelvic floor muscles, it doesn't support the urethra. So if you have any increased pressure in the abdomen, that will push down the urethra and stop the support. And normally, when you have pressure in your abdomen, which then push on your bladder, make you want to do a bit of a wee, your pelvic floor stops. It stops the urethra from moving down, and it squashes the urethra. Okay, so it compresses the water pipe, and that stops you from doing a wee, essentially, when you have abdominal pressure, coughing, sneezing, these sort of problems. Now, when you have a weak pelvic floor, the principle applies for an idea. If I had a water pipe, a hose, and it was on the pavement, and I stood on it, stamped on it, the pelvic floor is the pavement, and that stops the water pipe from dropping. Okay, and then you squash the water pipe, you squash the hose, and that stops the water from flowing, which is what we want. Now, if you have a weak pelvic floor, your hose is over a muddy puddle, okay, and you step on that muddy puddle, all that happens is that hose drops down, so it drops caudally down, and then no longer is that water pipe pressed upon, okay, so there's no compression of the water pipe, so then you can't stop the urine flow, and then you leak. That's what happens. And that's the majority of, in a nutshell, that's the majority of people with stress incontinence down to pelvic floor. The water pipe analogy is really easy to explain to patients. I wouldn't go through all the detail, but the water pipe analogy is really important. Tell the patient that you need a hard, strong supporting surface underneath your water pipe to stop it from leaking is really important. The other causes can be internal sphincter deficiency. I'm going to show you a slide in the next one about a little bit about that. But that can be caused by neurological injury, pelvic radiation, cancer radiotherapy, these sort of things. Neurological disorders to do with the way the nerves innervate the area, aging, atrophy, these sort of problems. So your bladder this is someone's bladder. Okay, I didn't draw this. Okay, I've stolen it from YouTube, but this is someone's bladder. As your bladder fills up to about 50% capacity or so, your internal sphincter will naturally open, and alongside with your detrusor muscles and the bladder muscle, that sort of squeezes, it gets stretched out and says, yeah, I need to do a wee. I'm getting that inclination. I need to go and pass urine. The smooth muscle over here will relax. Okay, so reflex from the pons. You don't need to know about that too much, but it's a reflex from there. And then what stops you from passing urine is your external sphincter, which is to do with the pelvic floor muscle, and your skeletal muscle, which is your voluntary control. This is what you say, I need to do a wee, but I'm going to hold it in. Okay, that's what you're doing. You're squeezing over here. Now, if you have damage to that pelvic floor, this is what we call the vaginal hammock hypothesis. What happens is this water pipe will drop below the pelvic floor area where it should be. There's no longer compression and support. You're no longer able to squeeze and stop that urine from flowing, and then you leak. So that's what happens with stress incontinence. Okay. So what can we do to manage stress incontinence? So we can look at what is the cause of the abdominal pressure increasing. Simply enough, do they have a chronic cough? Do they have asthma? Do they have COPD? Are they smokers? Are they constipated? This is, are they got increased abdominal pressure burden? Do they have this urethral hypermobility? Have they had previous surgery? Have they had previous surgery, or do they need previous surgery? Do they have a prolapse that can be dealt with a pessary? Do they have that bearing down sensation? Do they, have they seen a prolapse? Do they feel like something's there that's not there? Have you done a speculum on the patient, doing a smear and notice that there's a small prolapse? Is that related? Okay. And then internal sphincter deficiency can be, like I say, aging, can be atrophic vaginitis from a lack of estrogen as we get older. Interestingly enough, if you want to manage that, that's be through estrogen pessaries for postmenopausal ladies is more effective. So that's really the key point here. Occlusion. So there is actually treatments that aren't commonly used, but there are treatments that I read you can use for urethral control. So people with very poor, not palliative, but very poor stress incontinence control, and they actually use like a plug-like device to prevent urine flow. As in, I've never seen it used in practice, but it can be used in certain cases. People that can't really wear pads when they're going out and about. Pelvic floor exercises is what we're going to talk about. It's really important that everyone knows how to do pelvic floor exercises. All clinicians need to know. And pelvic floor exercises applies to men and women. Okay. But obviously, a large portion is women, but it's important that we all know how to do the pelvic floor exercise and how to explain that to the patient. So I've got a next slide on that. Treatment may just be pads, because it may be that pelvic floor has failed, not for surgery. Pads is the important thing. Weight loss, high level of obesity, pressure on the abdomen, that's going to cause more stress incontinence. So trying to address the obesity may be all that's needed to support that pelvic floor. Duloxetine is a treatment. I've got a slide on that as well coming up. You just have to bear in mind that duloxetine, when you start any antidepressant or such, you have to warn patients about possible mental health side effects during initiation, increased agitation, anxiety sort of symptoms that can develop the first couple of weeks when you start someone on duloxetine. And obviously, is the estrogen treatment appropriate? Do they have atrophy? Do they need estrogen to nourish the structure and the skin surfaces around the water pipe to help improve the function of that sphincter? So pelvic floor. How do you do pelvic floor? Okay, so it's the idea called Kegel exercises. Now, how do we do Kegel exercises? So what I tell patients often, the first thing I tell patients to do is when you go to do pass urine next, stop the stream. Feel that feeling that you had when you stopped the stream, and let go of the stream and stop the stream, and then learn that feeling of what muscle you're tensing to stop the stream, because that's essentially the pelvic floor muscle that you need to tense when you're doing your Kegel exercises. So now I'm the only one on camera here, so I'm going to tell everyone how to do pelvic floor exercises. We can all do it together, or you can just listen in and see how we do it. So the first thing that we tell patients to do is tighten their back passage anus as if they're going to prevent passing flatus, so passing gas. So you don't want to be squeezing your buttocks and going up on your chair. Then you're doing it wrong. You want to be relaxed on your abdomen, relaxed on your buttock, and you want to squeeze your anus as if you are stopping gas to pass. I'm doing it now, okay? So you can see there's no facial expressions. And then the next thing you tell the patient is you want to tighten the vagina to feel as if it's pulling upwards to the umbilicus. Obviously, this doesn't apply for men, but for women it does. The lady, if she wants to practice at home, when she practices at home, she can insert a finger into her vagina to feel that tensing and the right sensation, because that would mean that she's tensing the pelvic floor. Often, when it's taught in clinics, you'll show the patient that way. But it's really important when they do this, that the lady or the man doesn't apply pressure to the abdomen. Your abdomen needs to be relaxed, so you need to tighten your anus as if not passing gas. Then you need to tighten the vagina or that pelvic floor area, pulling it upwards towards your navel, your navel towards your umbilicus, and then with your abdomen nice and relaxed, and then you want to tighten as if you're stopping the urine flow. Once you do it and you get that feeling, you can just keep doing it all the time without and no one needs to know that you are doing it. What they do say is that if someone's got pelvic floor problems, stress incontinence, they should do a 3-month course of pelvic floor exercises where you do a pelvic floor maneuver, Kegel exercise for 5 seconds, 5 times every hour that you're awake, which sounds like quite a lot, but it's for 3 months. And after that, you can do it as required, but try and doing at least a few times over a day. There are things that can be used to support that and help people to do that for ladies. So there's something called vaginal cones. I'm not going to go into too much detail over that. This is something that can be given by pelvic floor physios. But there's a device called Kegel A, and there are other devices that are applied. Essentially, there are these devices that ladies insert into the vagina that they can squeeze on to prevent the cone from falling, and then also to practice the movement. The Kegel Aid's got a special device that will help the lady know if she's doing it correctly or not. But there's lots of other devices around. Use the pelvic floor physio would explain that to the patient and show them how to use it. But there's lots of good self-help advice from the drug companies which sell it. So surgery, majority of the time when pelvic floor fails, surgery is the next best option. And usually it's some sort of sling-like device. Previously, it used to be a synthetic sling, like a plastic like device, like sling, that they place underneath the water pipe over here, and then they do a cut. It goes through the skin by the pelvis, and then they snip it, they cut it. It's not tight, it's just there to give that support, and then they stitch back over. And now what they use is autologous fascia, so they use the fascia layer from the abdomen. So they do a small cut of the suprapubic fat pad just above that, take a bit of the fascia from there, which is the part that holds your abdomen to where it is from pushing out, getting a hernia, and they use that instead, to prevent any long-term sort of problems. There are special centres in Bristol, other parts of the country, which will remove the old synthetic tapes which may have eroded or not be working, and then they can insert this. Majority of the time it works, good success, 80% of the time. 14% does a partial success, and in very few cases is there no success. The other option is bulking. So this is a very low risk procedure where the surgeon will insert a cystoscope, and then they'll insert a bulking agent around the urethra, and that will allow to support that pelvic floor, which is lacking, and strengthen that sphincter. So the sphincter is a bit weak. They have some more support that they don't need to overly tighten it to affect the they don't have to overly tighten the sphincter to stop the urine from passing, so they have a bit more support there. It works quite well for most people, but it's not necessarily the best long-term solution, and it can fade off in effectiveness over time. Duloxetine is, can be quite helpful. It increases the urethral tone, so it helps to improve that sphincter control and causes more pressure there. And it works on that by increasing this pudendal motor nerve, which is the nerve which goes towards the genital area and the bladder area, and increases the output of that nerve to do so. And the other major cause of incontinence is urge incontinence. Okay, urge incontinence is usually down to detrusor overactivity. So detrusor is just the muscle of your bladder being overactive and spasming early. Normally, we feel like we have to pass urine at 3 points, normally about 150 to 200 mils, and then maybe about 300 mils to 350 mils, and then you feel like you're bursting. When you go to 400, 450, 500, then you feel like you're really bursting. Most people, bladder capacity is under 500 mils, about 450 mils is the bladder capacity. And at that point, you feel like you really, really, really have to go. People with detrusor overactivity, so overactive bladder, they essentially feel like they have to pass urine earlier at each stage. They can pass the stage of that feeling of urgency. They need to go past urine, but it can be at earlier points of the bladder filling. Okay. Detrusor overactivity can be triggered off by BPH or urethral obstruction. BPH is benign prostatic hyperplasia, and that can be because you're pushing into pressure, and then your muscle has to squeeze harder, and it gets irritated from that effect. It can be caused by inflammation, so i.e. recurrent infections or current infection, interstitial cystitis with non-infective inflammation, stones, bladder stones, cancer in the bladder. So this is where it's important to think about cancer as a red flag. Foreign bodies, you do see that rarely, but from time to time. And pelvic surgery can have an effect if nerves are affected, particularly if someone's had a hysterectomy, and then the nerves which sort of control and sort of like relax the bladder muscles, it's cholinergic muscle nerves get affected, and then there's oversympathetic, too much sympathetic activity, like too much stress response in the bladder, and the bladder feels like it has to keep going. So treatment, there's lots of treatments. Okay, but the options we have is really diet. So diet's a really, really good option. Look at our spice, look at our acidic content of our diet. Sometimes that can be a trigger and an irritant to the bladder. Chocolate, caffeine. We always talk about caffeine. Even decaf has caffeine in there, so just to bear that in mind as well. Some people avoid drinking water, and actually avoiding hydrating your bladder also causes irritation. So you need to drink a reasonable amount of fluid. The guide is usually about 1.5 to 2 liters a day is usually a reasonable guide, which I usually say to patients is about 5 to 6 mugs of fluid a day, which most people can drink. There are other options, of course. There's tricyclics, so not amitriptyline, but imipramine is indicated and possibly used for overactive bladder. We don't commonly use it because of obviously overdose complications. A side effect profile cannot be great with that. Amitriptyline can be helpful for people with overactive bladder, but it's not normally like first line option. Sometimes they say to give imipramine with oxybutynin can be quite helpful. Anticholinergic, so what that does is that boosts that muscarinic, that effect on the bladder, to relax the bladder, to counter that sympathetic, that agitated, angry sort of effect that the sympathetic system has on the bladder to make you want to go and be irritated to go. So any of these drug options are fine. Nice, go for the cheapest option for effect, but any of the options are equally okay. You just got to be careful with the cholinergic burden. Trospium has a high cholinergic burden. Okay, so why that's important is if someone's elderly, 80s plus, frail, can lead to increased levels of episodes of confusion if they have an infection and those sort of things. Verapamil isn't normally something that we commonly use for overactive bladder, but verapamil does have effect to counter overactive bladder symptoms. We don't normally go around prescribing it for it per se, but if someone's got angina or those sort of issues and have verapamil, it's not, it probably would help them with this. Obviously, just be careful with on a beta blocker not to have both together. Mirabegron. Mirabegron's a good option. I think I've got a slide on mirabegron coming up as well. Mirabegron's really good as well because patients with who are elderly, you want to avoid this cholinergic burden. Giving them mirabegron, betamega, can have really good effect. The only real main point with that I always press upon is that you should do your blood pressure within the year when you start it, and you should have once a year blood pressure monitoring for anyone on mirabegron, because obviously it's a beta adrenergic agonist, so it can potentially elevate your blood pressure. So you need to monitor that, especially in elderly populations. Estrogen can be the case. People have atrophic vaginitis, irritated in the area, and that can make them feel like they have to go frequently. There can be other causes, like local causes why the urethra might be inflamed. Botox is an option. So basically, once we go through the drug options, really, and we're getting to know when patients have really severe symptoms, Botox is the next best option. Botox essentially, patient will go frequently every 3 to 6 months for cystoscopy, a camera in the bladder, and they inject Botox into the bladder muscle. But it works very well. There's a small risk of urine retention, but very low risk. The bladder drills, that are important as well. I'm going to talk about that in the next slide. And there is surgery, though seldom done. So bladder retraining, how do we do bladder retraining? What I tell a patient is schedule your voids, write it down, say, well, actually, at the moment I'm going every 20 minutes to the loo. I want to go every half an hour. And then try and hold until half an hour, try and hold until 40 minutes, try and hold until an hour, and slowly prolong those scheduled voids. Delay the void, okay? Go to the toilet. I'm really desperate to go to the toilet. I really have to go and pass urine. Go to the toilet, just don't pass urine for as long as possible. It may be annoying, but just hold it in for as long as possible. Whether that means you're sitting on the toilet, whether that means you're standing, whatever, but you wait there and you try and get past that urge. And if you can't overcome it and you pass urine, that's okay. You keep trying and you keep trying, and slowly your bladder will retrain, and hopefully the symptoms will be improved. And this is either the positive reinforcement to support people through that process. It's not going to be an overnight sort of thing. How can they prolong their void? Well, they can use simple distraction methods, tiptoeing. tiptoeing relaxes your bladder. Okay, so anyone here that's worked on urology, if you want someone to difficult to catheterize, you can sometimes ask them to tiptoe their toes back and forwards. It relaxes their bladder muscles and the sphincter to allow easier catheterization. So that can be helpful. Just relax. Cross their legs, counting, hopping can be a case. Quite a few different things that they can do. Whatever works for them, really. And then the third most important reason, really, is overflow. What are the causes of overflow incontinence? I'll try and speed up now, actually. So neurogenic and obstructive. Neurogenic can be spinal cord issues, nerve issues, diabetic issues, and obstructive is obviously BPH, prostate issues, strictures, etc. How we work up a patient is we do a urine analysis, we do a bladder diary. Bladder diary is fluid intake and fluid out. They don't necessarily have to measure the volumes, but it is helpful to measure the volumes of urine that they pass and how often they pass. It's quite key. A cough stress test is what you do in the clinic room. You get them to cough and see if any urine passes out. Speculum examination to look for prolapses. Post-void residual is very, very, very important. Anyone with the feeling of incomplete emptying after voiding, any man, especially particularly elderly, who who when passes urine feels like they're not emptying the bladder, it's always worthwhile checking a post-void residual, which is an ultrasound scan after they do pass urine to see are they retaining urine, because a lot of men may have chronic retention and they may have 400 mils in the bladder resting. You can most often percuss for it when you feel the abdomen, but it's important to scan for that, because in that case, giving them medication may put them into retention. And you may want to think about tamsulosin. You may want to think about referring to urology. You may want to get an urgent urinese. Is there any chronic high pressure retention? Do they need admission? Sometimes it's worth thinking about. You do see that from time to time. The urology doctors might do a cystoscopy to look for any clear urethral flow issues. Urodynamics can be done only really indicated for urgent incontinence, but only for select cases. Kidney function tests and HbA1c for diabetes, really. Just last few slides now. I think we're doing okay-ish on time. Referral. So you can always refer to pelvic floor physio. Is usually there's a continence team in each area, and you can refer to pelvic floor physio for patients. Sometimes it may be difficult for ourselves to explain to patients how to do pelvic floor, but as I say, it's really important that we all practice this at home so we can tell our patients how to do it and give them that support. But there are pelvic floor physios that will spend time and really support patients on that journey. And the guidelines do say to refer for that for 3 months of pelvic floor therapy. If no improvement with medication, you want to refer to urology or urogyne. Consider pessary insertion for prolapse. That's when you want to refer. Is there a structural cause? Have they had a hysterectomy? These sort of problems. Do they need to have? Is definitely they need to have surgery for their stress incontinence. And like I say, overflow incontinence. Do they have chronic retention and are they having overflow? Do they need to go to hospital? How urgent is their referral? Red flags, recurrent UTI. So that's a non-urgent 2-week wait, non-urgent cancer referral for recurrent UTI, 2-week wait for visible hematuria or persistent non-visible, and obviously neurological causes, back pain, motor power loss, loss of reflexes in the legs. There's something else going on behind it. MS, these sort of problems. They can present in this way. So consideration really now. So just have a think about your patient before you prescribe medication to them, and think about how easy it will be for them to do the pelvic floor exercises that you've prescribed for them to do. Think about their frailty. Think about how they're going to get access to pads. Find out your local team that will provide and support you with that. Would a social prescriber be helpful for this patient? Do they need other care support? That can be quite important for these sort of patients. Think about the confusion from anticholinergics. Think about the hypertension from mirabegron. Think about postmenopausal patients. Do they need estrogen pessaries? Okay, I've got 3 cases. Jazz, are we okay for time, or should we just do one case?
No, we're good for time.
Good for time, yeah. Okay, so I've got 3 cases. We'll just go over them, and then hopefully we get some participation from the audience. So we've got an 85-year-old man with urgency symptoms. He says to you, I just have to keep going to the toilet, at least every hour. So it's a bit annoying. My toilets are upstairs. I'm finding it difficult to get up the stairs. He's coming asking for a letter for his stair lift, not about the urine really. Rare incontinence, but sometimes you can leak a little bit whilst going up the toilet because can't get there in time. When you ask him a little bit more information, he tells you he's got hesitancy. He has to stand in the toilet for a little bit of time for it to come out, but it's definitely not as good as when he was 40. The flow is definitely not there. Just has hypertension, takes ramipril and atorvastatin. So does anyone want to shout out what they're thinking, what we could do, what we want to ask the patient, how we would manage this case?
Feel free to put it in the chat as well if you want. I did put a couple of messages in there, so I'm not too sure if the chat is working or not, but feel free to shout out.
Might not get anything. That's okay. So how do we approach it? Any in the chat, Jazz, or shall I go through?
Yeah, so BPH is
BPH
potential.
Yeah. That's it, right? Yeah, and absolutely. So you got a man here, 85. Most men, as we get older, or men, as we get past 50, we all produce testosterone. So naturally, our prostate will grow in size. It doesn't mean that you're going to have prostate cancer, but all prostates will grow in size pretty much. So it's natural to gradually develop these sort of symptoms. So BPH is the most likely cause for this patient. And that could be causing him some sort of urgency symptoms. You'd be really keen to find out, is he emptying his bladder well enough? Do you want to give him a trial of tamsulosin as a get-go? Obviously address his social issues as well. But do you want to give him a trial of tamsulosin? Do you want to be mindful about his blood pressure control? I would be a bit careful before prescribing him any sort of antimuscarinic, like to avoid the risk of retention. What you find a lot of the time in these sort of men is that they will have chronic retention of a certain amount of urine. So you just want to be a bit mindful before prescribing things like trospium or solifenacine, those sort of drugs. Just be a bit mindful about definitely not retaining any urine. And then you can give it a go and see how he gets on over about a month to 2 months. You might want to bring him in to examine his prostate size. He's 85, so you don't really need to do a PSA on someone past 80. Okay, you treat that based on red flags purely, so not necessarily needed in this case.
Balraj, I was going to, with the regards to the PSA, with a lot of awareness as well. I think a lot of patients do come in and ask for it. It has its limitations, so that there's certain criteria I think you'd follow, and probably information. What would you pass on to patients when they do request unnecessarily, sometimes sort of asymptomatic?
Yeah. Absolutely. So the PSA is constantly being asked for now in general practice because of rightly or wrongly, because of awareness about the king. There's been a campaign from prostate cancer. There was that famous comedian, and so there's been a lot of awareness and people saying, right, you should go and get your PSA screening done. But there's a problem with that because the screenings, PSA test is not really designed for screening test, and there's a lot of false positives, a lot of false negatives. It's a lot of time that you'll do it, and then what will it lead to? And this is the prostate cancer is so common. So 80% upwards, people over 80% of people over 80 have prostate cancer, whether they know it or not, whether the PSA is raised or not. The only way you're going to know is to resect their prostate and then put it through slides and have a look. But is the prostate cancer going to be their cause of death? Is it going to limit their life? Is it going to affect their quality of life? That's really the important point. That's never really spoken about in the PSA screening campaign, which is a really big shame. And that's why the medical people are quite against this screening project, because they're saying, yes, do the PSA screening, but they're not saying to patients, this is a consequence of screening. There's always a consequence of screening. There's a financial cost, there's an investigation cost, there's a burden on patient time, clinician time, there's a burden on investigations, which may not change the course of that patient's life. So then why are we doing it? That's what we've got to ask ourselves. It's a really good leaflet. I'll share it after this in the comments from, if you search in BAUS, so BAUS, that's the British Association of Urology Surgeons, BAUS PSA screening. They've got a 2-page information sheet that's really, really helpful. Lots of information on there about whether you should do it or not. What our role as clinicians is to guide the patient through that. Ultimately, if the patient wants to have it, and you counsel them, then it's perfectly fine. I often give the patient that information leaflet to read through. I explain through it, and I'll give them blood form. And if they still want to go ahead, they're more than welcome to do it. I always tell them, that if it's raised, we may need to repeat it. You may need to come for examination. You may get referred on 2-week wait pathway, so make sure the patient's aware about that. In Birmingham, now they've changed the 2-week pathway. So if they have a raised PSA, you have to do a DRE before referring the patient on to urology, just because of the way this campaign's affected in Birmingham. In Black Country, we don't have to do that. We follow the WMCA pathway, so West Midlands Cancer Alliance pathway, and you don't necessarily have to do a DRE, though you should. But and that's largely down to the high levels of high PSAs coming in. PSA screening above 80 is not really indicated, because it's hard to know what number's right for that patient. PSA screening before 50 is not really indicated unless a strong family history, unless there's a compelling reason for it. And if a PSA is less than 0.1, and so less than 1, or definitely less than 0.5, it's highly reassuring for that patient. It's not an exclusion against prostate cancer, but it's just highly reassuring for that patient that they don't need to do an annual repeat of PSA that some people want to do. Yeah. But it's not easy now, and I'm getting a lot of requests for it. I think every surgery is. Yeah, and some surgeries are actually doing PSA campaigns, but I suppose there are always consequences to doing things a lot like that. Yeah. So this is case number 2. So just one more case after this. There's a 42-year-old lady who's having incontinence on carrying shopping bags. So she's a young lady. She's not middle-aged yet. She's still young, I'd say. She goes to Morrison, to Tesco, wherever she goes. When she's carrying shopping bags, she's training to carry it, and she's often finding that she's a little bit incontinent in that time. She's worried of the smell, and she didn't really want to bring it up, but she's finally mounted her her confidence and courage to come in and tell you about it. She does get a feeling of pressure down below. She says to you, I do feel uncomfortable, and I do feel uncomfortable during coitus, so during intercourse, I do feel uncomfortable. I don't feel like everything's quite right down below. And she's worried about, she tells you, I'm worried about cancer. I'm worried about what could be happening to me. She's aware about ovarian cancer and these sort of problems, and she's not sure. Past medical history is nil. She's a fit and well lady. She's had 2 children. Okay, 2 pregnancies and 2 children. Doesn't take any medication. What would we do in this situation for this patient?
So you mentioned possible prolapse.
Yeah.
Examination.
Examination. That's it. Yeah, I think that's really important. Possible prolapse. Ask her, is she doing pelvic floor? Okay. People might not want to put their hand up in this forum, but how many women on this call are doing pelvic floor exercises regularly? Majority of people don't do it. Even medical professionals don't do the pelvic floor exercises, even though we know we should be doing it. And so it's a good idea to ask her, bring her for examination, probably need a spectrum examination, bimanual, get her to cough, feel for cough impulse down below, and speculum to examine the same. Does she need referral to community gynae for pessary potentially? Does she need pelvic floor exercises? What can she do about it? Can we refer to pelvic floor physio? These are the sort of things I'll be thinking. You might want to do blood test screening. You might want to, might not. Check her weight. What's her, is she got obesity? Make sure you exclude urgency symptoms as well. Always dip the urine. That's what I would say for this patient. Yeah.
With a couple of mentions around just checking on previous smear tests and any warranted sort of swabbing, rule out infections.
That's exactly it. Yeah, swabbing. Yeah, if they've got PID or pelvic inflammatory disease, BV or trichomonas, that can make things a bit worse. Smears are important because they may be commented at that point that she might have had a small prolapse at that point. I guess another point that I've got to mention as well is with the pregnancy. She's had 2 pregnancies. It doesn't sound like too much. You see some ladies that have had 8 pregnancies. But how did she deliver? Was it, was it normal delivery? Did she have a section? Was it with forceps? Were there tears? That's all really important because that may have really compromised her pelvic floor at the time. Did she have incontinence after pregnancy and she's not really coming talking on about it then? Did she sort of manage with it? Is she getting close to menopause and having some menopausal symptoms and it's more prominent now? There's quite a few factors, aren't there, to sort of think about. It definitely needs an examination and she needs reassurance as well about that, if she's naturally worried about other things that could be causing it. And the last case, for got a 60-year-old female here. She avoids drinking fluid. Otherwise, she has to run to the toilet every 10 minutes. She drinks any water, she'll be in the toilet in 10 minutes and she just can't manage. She's going out, she won't drink anything. So she's really struggling with that. It's got worse over the recent years. Definitely got worse the last 5 to 6 years, she says. Whenever she coughs, she can leak urine. Sometimes she has coughing attacks, and it can be particularly bad. And it's she feels quite embarrassed by that when she's at work. She's got COPD. She's got obesity. She takes her inhalers for COPD. I won't say the brand, but any of the inhalers. What kind of things are we going to be thinking about for this patient, and how do we sort of manage this patient? What do we think?
Is it stress incontinence?
Yeah, absolutely. Yeah, so she's got clear stress incontinence. She's got a clear cause behind it, COPD. Is a COPD well controlled? What's her CAT score? Is she still smoking? Does she know that she needs to stop smoking? How are we going to support her with that stop smoking? Are you going to refer her to local stop smoking or pharmacy first to support her with that? Does she need some advice on this? How are we going to manage the urgency that comes with it? Does she need medication? Does she need to do some bladder drills and some pelvic floor exercises? She's 60. She says to you that she's having symptoms worse since the last 5-7 years. When did she go through menopause? Does she need estrogen pessaries? Do you want to examine her and check for atrophic vaginitis? So these are the sort of things I would be thinking about. There's no harm in trying things out. Often things come mixed when postmenopausal ladies. Often they get mixed stress and urgency symptoms. Often, pelvic floor exercises that aren't being done, and really, I really try and focus a lot on doing pelvic floor exercises and doing pelvic floor drills, because that will reduce medication burden. And really, every time you speak to them about this, is say, well, what are we doing about pelvic floor? How are you getting exercises? Do you need help with that? Let's go over that. because if they can do that and they can strengthen their muscles at the right age, then it helps tremendously. If she's 80, the likelihood of pelvic floor returning to good function is really unlikely. But if she's 60, and you can give her estrogen pessary, and she can do pelvic floor exercises, can she make a good recovery and control her symptoms reasonably well? So that's what we'll be thinking about. Obesity, do you want to refer to the local help lose weight program? Do you want to talk about obesity? That's very important sort of questions. Okay, so that's my questions, and that's my questions. That's my slides. I'll close my. I'll stop sharing now. So I'll press this button, and we can see if you have any comments or any questions that people want to talk about.
We talked about pelvic floor quite a bit. I know you touched upon it there. Is there an optimal time, sort of post just after delivery, or is there any time where it potentially is too late, or sort of age is no barrier? If you're referring on.
Yeah, it's only too late once the patient's gone far beyond menopause. Then it's of little benefit. But pelvic floor drills can still be helpful. But if someone's, like I say, of menopause in the 50 or 49 something, and then they're in the late 70s, pelvic floor may have less effect for that lady. But it's we should always try and encourage patients from the get-go. Once they've recovered from the pregnancy and the feeling back to normal, to really try and do pelvic floor as much as possible. And I usually tell the patient, we can do it together in the consultation room, and just make sure that everyone's make sure that she's comfortable with doing that.
And I think just sort of add on to that, the comment in the chat, is there an emphasis on pelvic floor training during the pregnancy, antenatal, or sort of post-delivery with midwives, health visitors, or is that something that's covered?
It's really important, actually, and I don't think it is well covered. I think they often talk about it in the antenatal classes. So when ladies go to antenatal classes, not everyone goes to there. They talk about it there. But it's not commonly spoken about unless you raise it as an issue that's affecting you. And maybe it's something that's important to incorporate in a 6-week mom and baby check to just re-emphasize that, or maybe it's good to do a campaign and just text people out, a YouTube video from the NHS website about pelvic floor exercises. There's some quite good things that we can do just to gain awareness and promotion for this.
Brilliant. It's a question. I think Uzma's got her hand up as well. Uzma, do you want to come in? Okay. Floor's yours, Uzma. I think you are unmuted. Can't hear anything. If you want, Uzma, just feel free to drop it in the chat if your mic's not working. The other question I would ask, in terms of treatments, how many treatments would you try in terms of anticholinergics and others?
Yeah,
before
absolutely.
You'd look at sort of onwards referral and further investigations.
Yeah, usually we try so 3 months of pelvic floor, at least two anticholinergics, and if there's some benefit, try to add in mirabegron, and see how they get on with that. And if still really symptomatic, then to refer on, and then also to consider at that point as well, they might actually have a prolapse causing their symptoms, and so maybe to examine for that or to refer to gynae for that. So just about, I'll give it at least 3 to 6 months and try at least 2 antimuscarinics. So any of your choice, oxybutynin, solifenicine, trospium, your choice, whichever you want to go for. Might say to go for the instant release, okay, rather than modified release. That's based on cost benefit, so it's just down to personal preference and discussing it with the patient about what suits them the best, really.
Okay, that's great. Thank you. Uzma's just dropped a question into the chat. It was Yeah, do pelvic floor exercises work in women who have gone through premature ovarian failure or menopause? Those that are showing signs of menopause a little bit earlier.
Yeah, if they're on it, yeah, it'd be okay as long as if they, the reason why it's less effective after time is because of estrogen deficiency. So they've gone for premature menopause and they're on HRT. There's no reason why they can't do pelvic floor and have good success. It's only if you're in a state of no return, so to speak, and then you've got a high lack of estrogen deficiency, or you got a large prolapse, or then the benefit is reduced. But yeah, there's always a benefit for these people, for these patients, and for men. Men after they go through TURPs, TURPs, prostate resection, often they get incontinence for the first 3 months, and they're told post-op to make sure that they do these pelvic floor exercises to try and strengthen their sphincter. So it's not just women, so it's men as well. It's important for as well.
So there's no real contraindication, I think, for any group for pelvic floor, whatever age or any comorbidities.
Yeah, as long as they can follow the instructions, it's okay. Yeah,
that's great. I think does any more chat if you want to raise your hand? Otherwise, we'll bring this session to a close. Brilliant. That's great. Well, thank you. That was a lot of information. I think you covered there for us, Balraj. It was hopefully you all found that useful. Yeah, Nicole's just dropped the feedback form, so